Hello, everyone, and welcome. I'm excited to be here today to talk about medical students' disease, also known as nosophobia or second-year syndrome. On this first slide, we have the title of our presentation. Over the next few minutes, we'll explore what this condition is, why it happens, and how it affects medical students. So let's get started. So on this slide, we're looking at a common scenario that highlights the power and potential pitfalls of clinical storytelling. Imagine a third-year medical student right in the middle of their psychiatry rotation. As they read more about depression from the DSM-5, they start to see themselves in these descriptions. It's almost like they're starting to identify too closely with the diagnostic criteria. They read about symptoms, and suddenly they're convinced they have depression too, down to counting how many criteria they meet. This is a great example of how clinical stories can influence our perception, but it also shows how easy it is to become overly involved or even biased by the criteria we're learning. This situation underscores the importance of maintaining objectivity and recognizing how our own narratives can sometimes shape our clinical judgment. It connects to our overall theme today, how storytelling is a powerful tool in medicine, but it needs to be used carefully to avoid misinterpretation or bias. Now, let's look at a common scenario in the ER that highlights how storytelling influences clinical decisions. Imagine an anxious intern who, after experiencing only mild tension headaches, immediately requests a brain MRI. They're worried it might be something serious, like a tumor. They whisper to the senior doctor, "I think it's a tumor." Notice how their concern is driven by their interpretation of symptoms, and perhaps their fear of missing something. The senior, on the other hand, nods knowingly. This is a classic example of textbook-induced anxiety, where medical training and exposure to certain cases can lead to overdiagnosis. This story underscores a key point. The way we tell and interpret stories in medicine can significantly impact our clinical reasoning. It's a reminder to stay aware of how narratives influence decisions, sometimes leading us down paths we might not have taken if we focused solely on evidence-based guidelines. So on this final slide, we see a common but important scenario in clinical storytelling. Imagine a final-year student studying for an infectious disease viva, and suddenly they notice a slight tremor in their hand. Naturally, their immediate reaction might be panic, thinking, "Could this be Parkinson?" But here, the key point, it's crucial to remember that not every symptom or sign is a sign of a serious disease. In this case, the student's mentor quickly reassures them with a smile, saying, "Relax, you're just caffeinated and stressed." This highlights an essential aspect of clinical storytelling. Many signs can be influenced by factors like stress or fatigue. Recognizing these contextual clues helps us avoid jumping to conclusions and emphasizes the importance of understanding the whole clinical picture. So this story reminds us to stay calm, assess all possible causes, and not let anxiety cloud our judgment. It ties back to our overall theme, the importance of careful observation, contextual understanding, and maintaining a balanced perspective in clinical practice. Let's talk about the high-yield description of this condition. Basically, it's a temporary anxiety disorder that we often see in medical students. What happens is that students start to misinterpret normal bodily sensations as signs of the diseases they are studying. So, a normal heartbeat or a slight headache might be seen as something much more serious. It's quite common during the intense learning phases. This condition is also known by other names, such as nosophobia, which is a fear of developing diseases, or second-year syndrome, because it often occurs around the second year of medical training. Understanding this helps us recognize how the stress and knowledge overload can lead to these anxiety responses. It's a good example of how psychological factors interplay with medical education, and it underscores the importance of mental health awareness among students. Let's dive into the mechanism and pathophysiology behind this phenomenon. When someone is repeatedly exposed to certain health issues, they can become more aware of these sensations over time. This heightened awareness can lead to a cognitive bias, where normal bodily sensations are mistakenly interpreted as signs of illness. Essentially, the brain starts to see normal feelings as problematic. This is where pattern recognition goes awry. Instead of accurately identifying what's happening in the body, the brain over-identifies symptoms, making it seem like there's a problem when there isn't one. This misinterpretation can create a cycle where the person becomes increasingly focused on these sensations, reinforcing the perception of illness. Understanding this process helps us see how psychological and neurological factors intertwine in these cases, highlighting the importance of addressing both mind and body in treatment. It's a complex interaction, but recognizing these mechanisms is a key step in managing and helping those affected. Let's talk about the clinical course and its impact. Typically, the peak of challenges occurs during the early clinical years. This is when students often face the most stress and adjustment. The good news is that, for most people, these issues are self-limited and tend to improve as you gain more experience. It's a normal part of the learning process. However, it's important to recognize that this period can also cause some negative effects, like stress, difficulty concentrating, and sleep disturbances. These symptoms are understandable given the pressures of clinical training. Being aware of this helps us better support ourselves and our peers through these challenges, all while understanding that they usually improve over time with experience. Let's talk about prevention and management strategies that can really make a difference. First, reassurance and mentorship are key. Sometimes just knowing you're not alone and having someone to guide you can alleviate a lot of anxiety. Next, humor and perspective building can be powerful tools. They help shift your mindset and reduce the intensity of anxious thoughts. Then, we have mindfulness and self-awareness practices. These techniques help you stay present and recognize early signs of anxiety, so you can respond more effectively. It's also crucial to emphasize the difference between fluctuating anxiety and a real, progressive disease. Recognizing this distinction helps prevent unnecessary worry and encourages appropriate treatment when needed. All these strategies tie back to our overall goal: managing anxiety in a healthy way, empowering you to maintain balance and well-being. Let's take a closer look at the key pearl here. True illness, as we understand it, is consistent and progressive. That means the symptoms tend to stay steady or even worsen over time, despite reassurance or reassurance efforts. If a patient truly has a medical condition, their symptoms won't just come and go randomly. They'll follow a pattern of persistence or gradual worsening. On the other hand, imagined illness, or what some might call somatic symptom disorder, fluctuates with stress and exposure. So, these symptoms tend to vary depending on the patient's stress levels or specific situations. For example, when someone is under more stress, their symptoms might seem to flare up, and when they're relaxed, they might report fewer or no symptoms at all. Connecting this to our overall theme, understanding these differences helps us differentiate between genuine medical conditions and psychological or functional disorders. Recognizing whether symptoms are consistent and progressive or fluctuating with stress is crucial in guiding our approach to diagnosis and treatment. Let's talk about the exam and clinical relevance of this topic. You'll often see questions in behavioral science and psychiatry that touch on these concepts, so it's definitely something to keep in mind. For example, in medical training, you might encounter nosophobia, which is essentially an irrational fear of disease. Recognizing this can help in both exam scenarios and real-life clinical practice. But beyond the textbook, it's important to remember that empathy isn't just about understanding others. It also involves being aware of our own cognitive biases. That self-awareness can influence how we interpret patients, concerns, and how we approach treatment. Overall, this highlights how understanding these psychological patterns isn't just academic. It's directly applicable to providing better, more empathetic care. So the take-home message I want to leave you with is that medical students, disease is really a rite of passage, not a diagnosis. It's something many of us experience as part of our training, but it doesn't define us or our future as healthcare professionals. What's important to understand is that knowledge definitely sharpens our perception. It helps us recognize symptoms and understand conditions better. But Without the right context, that knowledge can actually blur our perception of reality. We might start to see problems where there aren't any, or become overly anxious about our own health. So, as we move forward, remember that developing clinical insight is a journey. It's about balancing what we know with the wisdom to see the bigger picture. And ultimately, maintaining that perspective keeps us grounded and focused on providing the best care possible.